Welcome back to the lecture of chronic liver disease in children. I am Dr. Amel Elfaramawy, Professor of Pediatrics at Shams University. In this segment, I will focus on liver cirrhosis as the end stage of chronic liver disease in children. Cirrhosis is the potential end stage of any chronic liver disease. Cirrhosis is a diffuse process characterized by fibrosis and nodular regeneration, which lead to distorted liver architecture. In children, the two most common forms of cirrhosis are post-necrotic as a complication of chronic hepatitis and biliary cirrhosis as a complication of chronic cholestasis. Less common is cardiac cirrhosis as a complication of chronic venous congestion. The pathogenesis of cirrhosis is related to hepatic stellate cell activation due to chronic hepatic injury leading to excess extracellular matrix deposition. Cirrhosis can affect all body systems, so there is hepatic symptoms and extrahepatic symptoms. The hepatic symptoms include jaundice, splenomegaly, ascites, GIT bleeding, or hepatic encephalopathy. A small shrunken liver may be present, but sometimes the liver is slightly enlarged, firm to hard in consistency with an irregular edge. Spider angiomas, palmar erythema, or digital clumping may be present. The extrahepatic manifestations of liver cirrhosis include cirrhotic cardiomyopathy, pulmonary hypertension, renal dysfunction, pancytopenia due to hypersplenism, malnutrition, immunologic dysfunction, as well as endocrinal dysfunction in the form of gynecomastia noted in males, irregularities of menstruation or amenorrhea in adolescent girls. Eventually, cirrhosis will lead to portal hypertension with variceal hemorrhage, ascites, encephalopathy, and liver insufficiency with encephalopathy, coagulopathy, and jaundice. Hepatocellular carcinoma occurs with increased frequency in the cirrhotic liver. The portal vein is formed by the confluence of splenic vein and superior mesenteric vein and receives blood from the inferior mesenteric, gastric, and cystic veins, so the portal vein is draining the majority of the splenic area. Portal hypertension is defined as elevation of portal blood pressure above normal. Portal hypertension is most commonly a result of cirrhosis, but portal hypertension without cirrhosis can occur. So the causes of portal hypertension are divided into prehepatic, suprahepatic, and intrahepatic. Although the clinical signs and symptoms may vary according to the specific original lesions, yet the consequences of portal hypertension are common to all. Prehepatic portal hypertension may be due to portal vein thrombosis, congenital arteriovenous malformation, or due to compression of portal vein by cysts in the porta hepatis. Portal vein thrombosis is the most common cause of portal hypertension in children. A history of neonatal omphalitis, sepsis, dehydration, or umbilical vein catheterization may be present. Causes in older children include local trauma, peritonitis, hypercoagulable states, and pancreatitis. In most cases, the diagnosis is not made until the age of 3 to 5 years when the child presents with hematemesis, splenomegaly with no liver disease. The intrahepatic causes can be divided to pre-sinusoidal in case of bilharziasis and congenital hepatic fibrosis, as the main pathology is pre-sinusoidal fibrosis around the portal venules. The sinusoidal causes are all the causes of cirrhosis as mentioned before. The post-sinusoidal causes of portal hypertension when the pathology is in the central veins, as in case of veno-occlusive disease. The suprahepatic causes or post-hepatic causes of portal hypertension are related to the causes of hepatic venous outflow obstruction, which was described in the previous lecture. The major manifestation and complication of portal hypertension is bleeding from esophageal and gastric varices. Other collaterals may be present causing caput medusa and hemorrhoids. There is splenomegaly that may result in hypersplenism that will lead to leukopenia, anemia, and thrombocytopenia. Ascites and liver failure may be present in case of decompensated liver. Upper GI endoscopy is diagnostic for the presence of varices and also therapeutic. Barium swallow will show filling defects representing the varices but rarely used now. Collaterals can be seen in CT scan of the abdomen. Doppler study will be helpful in the diagnosis of vascular occlusion, to measure the diameter of portal vein, to detect cavernous transformation of the portal vein, and to determine the direction of flow, which should be hepatopetal flow. Lab studies should be aimed at evaluation of the liver, evaluation of the blood elements as an evidence of hypersplenism. In children with portal vein thrombosis or Budd-Chiari syndrome, investigation of thrombophilia is indicated. Management of an attack of hematemesis is an emergency situation in which you should do assessment of the airway, breathing, and circulation, placement of nasogastric tube, giving nothing by mouth, establishment of 2 large bore venous accesses, volume resuscitation and packed RBCs transfusion according to the amount of bleeding, medical control of bleeding by vasoactive drugs as octreotide or sandostatin, which is a potent constrictor of splanchnic blood vessels, endoscopic injections, sclerotherapy or band ligation, mechanical control of bleeding by Sang's-Taking tube can be done. Vascular or surgical intervention may be needed in case of failure of these measures. Hepatic anti-failure measures should be used to remove the blood from the GIT in order to avoid hyperammonemia. After the control of hematemesis, the patient should be managed properly in order to prevent another attack of hematemesis. This can be achieved by medical treatment in the form of non-selective beta blockers, which is propranolol, in order to decrease the cardiac output and decrease the portal perfusion, endoscopic sclerotherapy or band ligation in order to eradicate the esophageal and gastric varices, vascular intervention by TIPS, which is transjugular intrahepatic portosystemic shunts, may be needed in case of failure of the above measures. This algorithm summarizes the treatment options in case of portal hypertension, and by this we came to the end of this segment. In the next segment I will explain ascites and I will give you a hint about liver transplantation.